Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual, and today I have a very interesting topic to discuss. If you're like me and have been working in the Pediatric Emergency Department for the last several years, you may have noticed that in the last maybe 5 or 6 years, we're seeing more and more adult-like diagnosis in the Pediatric Emergency Department. I don't think I've ever seen kids with cholecystitis and cholelithiasis as much as I've seen in the last 3 or 4 years. It seems to be a growing problem, probably more because of obesity. We see type 2 diabetes, we see cholelithiasis, we see cholecystitis, things that I don't believe my mentor saw 20 or 30 years ago. I could be wrong. But anyhow, I thought we'll bring an expert to the show to talk about this today, and my expert is somebody who's PEM trained, but also trained in adults. Today I'm going to be talking to Seth Ball, who's a pediatric emergency medicine doctor who trained in a 5-year combined residency program. I'm going to have him explain to you more about it. Thank you, Seth, very much for coming on the show. I appreciate your time. I know you're a busy guy with little kids and big jobs, and again, I know how busy you are, so I appreciate your time. Let me just introduce you to the people listening to the show. Please correct me if I'm wrong at any point. Seth, you are a pediatric emergency doctor in Las Vegas, and you are originally from
Indianapolis.
Yes, which I gotta be honest, I know nothing about.
That's all right. Flyover state.
Flyover state, I like that.
Yep.
Yes, you went to you went to residency in sort of an unusual way, I should say. You became a PEM physician via the combined EM General Pediatric Residency, which is a 5-year residency. Over the years, I've met a few people who did that. We'll talk about it. And because of what you did and because of what you do now, because I know you also work in the general ER, is that right?
I actually don't anymore. I spent about a year after training doing adult medicine as well. I'm technically credentialed to do so, but I just love working with the kids, so I haven't made it down there just yet.
You've seen the light.
That's right. That's right.
But I thought Seth will be a perfect person to discuss a very important and growing topic, which is adult diagnosis in the pediatric emergency department. And I think you'll agree, Seth, over the last 5 or 10 years, we see more and more kids coming to the pediatric ER with very much adult diagnosis. And we'll talk about it. I think the classic one is cholecystitis, which I see a ton of, which I think is very easy to manage for an EM doctor. It's basically preparing the child to the OR, not particularly hard. But I think many of us pediatric or regionally pediatric providers stumble a little bit about what do I do with the child with the first time diagnosis of hypertension? What do I do with the child with the first time diagnosis of diabetes type 2? I thought it will be a great person to talk about this. And let me just ask you, Seth, the question I ask all my guests. First question, what is your definition of a good pediatric emergency doctor? The one who does what?
Absolutely. And first of all, Yaron, thanks for having me. I'm excited to be here. I love listening to the podcast. I'm honored to be a guest. I was looking forward to this all day today. In terms of what I think a good PEM attending does, for the most part, it's remembering that there are needles hiding in the haystack. Especially nowadays, it's January. We're seeing a lot of these kids coming in with the viral URIs, but there's going to be some needles hiding in that haystack of myocarditis, of things just masquerading as the everyday mundane cold. And a lot of times I'll ask residents, did you think about this? Did you think about that? And inevitably, some of them will say something like, really, how common is that? And I don't, sure, these things might be uncommon, but if you don't think about it, you're going to miss it. And so I think remembering, and a good PEM attending just remembers that there are needles in the haystack, and you got to at least consider it. You don't have to work up every tachycardic viral URI for myocarditis, but remembering those red flags and remembering to look for it when a few things just aren't adding up.
Yeah, no, I completely agree. I think that's a great thing you teach your residents. I speak to the residents think about the most common and the most rare, no matter how rare it is. Sort of like along the same lines, I think as a PEM physicians, we got to think worst case scenario, no matter how rare it is.
Exactly.
Yeah, and every winter, that bronchiolytic newborn is actually a first presentation of congenital heart disease, and that really stumbles us. So yeah, I think those are great advice.
Yeah.
The second thing I wanted to ask you, Seth, and again, you are the perfect person to ask that. Over the years, I think when I was a fellow, I came across it for the first time. I honestly did not know it existed. You can do a 5-year residency, which combines general pediatrics and general emergency medicine. The people I've met over the years are people like you who end up practicing PEM, but obviously I have my own perspective because that's what I do. Is those are the people I meet. I'd love to know from you what attracted you to do this. I don't want to say weird. I don't want to insult anybody, but this very unusual course of training. The way I think about it, you got 2 undergrads as opposed to getting a master's. You know what I mean?
Yep. Yep. That's exactly right. And so I was lucky enough. I went into medical school. I think a lot of us, kind of bounce around in terms of what we're interested in. But my dad was a paramedic, and he got me interested in emergency medicine. And so that was something that I always loved doing. I loved the procedures. I loved the acuity. I loved never knowing what was coming through the door. But I just always loved working with kids too. And for me, I always felt like I wanted to do pediatric emergency medicine. I was lucky enough to train at Indiana, where for a medical school, again, these combined programs are very rare, but Indiana does have one of those. And I didn't know about it until my third year. I was on my peds cardiology rotation. And my senior, who was at that point functioning as a pediatric resident, was a combined resident. And so he told me about, I do this for a couple of months, then I go do emergency medicine for a couple of months, and I come back and do this for a couple of months throughout his training for 5 years. And that really sparked my interest in the combined program. In talking with the folks at IU, I learned that if you do one categorical residency followed by a fellowship, inevitably it's going to close the door to something else. And so if you do peds followed by PEM, you can't see adults in the emergency room. And for some people, they don't want to see adults in the emergency room, and that's perfectly fine. If you do EM followed by PEM, you can't see kids either as a hospitalist or as an outpatient. And at that point in my career, I just didn't want to close those doors. And so I figured, let's do the combined program. If I'm lucky enough to match into it again, they're pretty rare across the country. And so I was lucky enough to match, and it was a good 5 years. It was long residency, but it was a good time.
Very nice. Yes, that's great advice. I kind of also tell people along the same line, think about what your end goal, and if that's what you want to do, that's how you should do it. So for me, I knew I only want to take care of kids. I went the pediatric route, but I do like the option of possibly one day practicing general pediatrics. I guess for people like you, if you want to practice general emergency medicine one day, you can still do that. So that's definitely true, and good advice.
Yeah, and it was really good training too in the adult emergency room. Lots of procedures available, a lot of sick patients. So that was a nice bonus.
Yeah, absolutely, a lot bigger than on the pediatric side, that's for sure. So Seth, the topic of today's discussion really is something that my anecdotal experience in the last 5-10 years. I finished fellowship about 10 years ago, and it's really impressive. I don't think I've ever seen so many quote unquote adult diagnoses as I have in the last 5 years or so. And again, this is all anecdotal experience, but I'm pretty sure it's true across the board. Again, in the last decade, we see more and more obesity, and with that, more adult type conditions, namely hypertension, type 2 diabetes. And those are things that, for the most part, I think those of us who practiced or did residency in general pediatrics are not as comfortable treating. So, in my mind, I know that this child with 140 over 100 blood pressure is probably not going to go home and get a stroke, but I'm a little hesitant to send them home. And that's something that I'm sure you guys are a lot more comfortable. So I figured we'll come to the show and have you talk about those conditions. So tell us, how would you advise us pediatric providers or original pediatric providers deal with those situations? Let's start with maybe hypertension.
Yeah, absolutely. And you nailed it. That obesity epidemic is just, it's really wreaking havoc on our pediatric population right now. And we're certainly seeing this kind of creep of commonly adult quote unquote problems in our pediatric population. Like you said, biliary disease. I mean, I just didn't see that much of it when I was in residency. And then I moved out here to Vegas, and it's monthly where I'm diagnosing a kid with cholecystitis or choledocholithiasis or gallstone pancreatitis, and all these seemingly adult problems are really kind of popping up in our pediatric population. And they're really putting that old adage of kids aren't just little adults, really putting that to the test nowadays. They're slowly becoming little adults. But for high blood pressure in general, like you said, the kid who comes in with that high reading, and you get some notification, it's red on your EMR, whatever it is that tells you that this is an abnormal number. A lot of times I'm not going to start that kid on an antihypertensive. There's a lot of things that are going on. They're anxious in the emergency room, they're in pain, whatever it is. They're not someone I'm necessarily going to start on an antihypertensive medication. And for me, what backs that up is we would have patients where the primary doctor would, for adult population, we would have patients where the primary doctor would send the adult to the emergency room completely asymptomatic with a shockingly high blood pressure, 210 over 140, something that, makes your eyes pop, right? And so you're scared their eyes are actually going to pop out of their socket, but they're not. It's been proven that you really don't need to do anything. They need to take their antihypertensive medications. As long as they're asymptomatic, we would send those patients home. And so for me, the kid in the emergency room with that completely asymptomatic high reading, I'm going to tell the parents about it, say, you really need to get this followed up. You need to have it checked in an appropriate setting, which is not here. And so I'm comfortable sending those kids home as long as parents understand this is something that needs to be followed up and can lead to long-term problems if this is real hypertension. In terms of what is hypertension in peds, again, we have that 120 over 80 number, which is a good kind of starting point. But for the younger kids, the way I look at it, if you think about a kid after 1 year old, you start with 100 over 60 and you add 1 to each of those numbers every year of life. So 101 over 61. And by the time they're 20 years old, it's 120 over 80. And so that would be a relatively normal number. For me, and this is what we would get concerned about in adults, and doing a little reading on this is what would be concerning in kids too, is when they come with actual hypertensive crisis, which is hypertensive urgency, which is a severe elevation in the blood pressure without end organ involvement, or hypertensive emergency, which is when that number is so high that it's causing end organ problems. And your end organs, you got to think about your heart, your lungs, your brain, your kidneys, things like that. And so when kids present with hypertensive emergency, that's when we're really going to jump into action. Hypertensive emergency is pretty rare in kids, really hard to study because of how rare it is. But again, that gets back to our needle in a haystack talk, where it's going to happen. We do see these kids and we certainly don't want to miss it. The incidence is less than 1%. But the morbidity is high. It's as high as 4%. And for kids coming to the emergency room with hypertension, hypertensive crisis was actually found in some studies as high as half of that population. It kind of ranges based on the study you're looking at, but somewhere between 15 and 54%. Primary hypertension in kids usually not going to lead to hypertensive emergency. So really it's the secondary causes of high blood pressure that are going to cause hypertensive emergency in kids. In adults, again, that's a different story. It's usually primary. But for kids, it's going to be more renal disease. Post-strep glomerulonephritis can cause hypertensive emergency, HUS, sympathetic crisis, whether they're abusing a substance or have a FIO or something. Again, these kind of unicorns are needles, but these things can present. Or if they have previously diagnosed high blood pressure and they're supposed to be taking medication for it, and there's just a non-compliance issue or a compliance issue, then that can certainly cause rebound. Again, we have the kids on clonidine, whether it's for high blood pressure or not. When you stop taking that, you get a pretty significant rebound in your blood pressure, and so that can lead to some big problems. Most of the time, these problems are going to, again, come from renal problems, endocrine, ingestion, drugs, other medications that they're taking, tumors. And the one that I think this was something that as a resident, I did a lot of sim for our pediatric residents, and talking about adult problems in kids. You can talk about eclampsia and preeclampsia presenting that way. And so that's something where it's something where, again, do you see it that often? No, but you really got to know if that's the case, because that's going to lead to some significant problems. When kids do come in with severe hypertension, and it's something that we need to act on right away, the most common presenting thing is actually going to be hypertensive encephalopathy. So they're going to have headaches, nausea, vomiting, confusion, blurry vision, and oftentimes they'll end up seizing if nothing's done about it. Infants, again, they can have high blood pressure too, severe high blood pressure that causes problems, and that's going to present as infants typically do when something is wrong: poor feeding, trouble breathing. What do I do when I see these kids? Again, I've seen very, very few. I can say I've diagnosed hypertensive emergency in kids, but it's very rare. But the things you got to think about, again, if we're talking about the kid who is symptomatic, the kid who has that severely high reading, you want to look at a urinalysis for proteinuria, your BUN and creatinine, because we're talking about the end organ damage, electrolytes. You want to look at, or at least consider, catecholamines, get a chest x-ray, get an EKG. You're going to look for left ventricular hypertrophy for signs of chronic high blood pressure, pulmonary edema if they have difficulty breathing. And those kids who have the altered mental status, or again, that most common presentation of hypertensive encephalopathy, we'll talk about bringing the blood pressure down, but they are, I think, obviously going to need intensive care admission, and oftentimes they'll need a brain MRI. When it comes to treating it, we want to bring the blood pressure down, but not too quickly, because if that patient, if it has been chronic and they've been used to living at that and just now presenting with symptoms, you don't want to drop it too fast, or else they're going to feel kind of a relative hypotension, basically. So we want something that's fast on and fast off. That way, if you turn it on and their body is naive to that medication and you see it plummeting, then you can turn it off and it gets out of the body quickly. So things like your loop diuretics are going to help to get rid of the fluid. Beta blockers are kind of the go-to for kids. Angiotensin converting enzyme inhibitors like enalapril and clofidipine, those are going to be kind of the more common ones nowadays used in the adult ER. I don't think pediatric emergency medicine providers typically use those kinds of medications, but those are more first line when it comes to adult patients presenting with hypertensive emergency. Basically, for me, when a kid comes in and I see an elevated pressure, similar to any abnormal vital sign, I want to find a reason for it. And so, is that child just really anxious? Are they in pain? Is there something else contributing to their elevated blood pressure? I usually can write it off as something else going on. If I can't and they're otherwise okay, tell the parents, look, this is a high blood pressure reading. There's probably something confounding that being here in the emergency room. Everything else seems okay. You can go home. But in those kids who are otherwise symptomatic, altered, blurry vision, it can even just be abdominal pain, like we said in the infants, poor feeding, trouble breathing, we want to look into that a little bit more. And starting with labs, I think, is a great way to do that.
And what I hear you saying, Seth, that's actually really important. It sounds to me like in the adult population, you're very unlikely to find something because it's almost always idiopathic hypertension and whatnot. But in the younger population, it's worth a shot because likely you'll find something. Maybe not today in the ER, but after admission or so.
Yep, absolutely right. Again, a lot of times in adults, it's just primary high blood pressure. Kids are starting to develop that more, but especially if you see a younger patient or a patient that you don't think has other confounders, if they don't have the obesity, if they don't have the family history of high blood pressure, the younger the patient and the higher the reading, the more likely it's going to be secondary, caused by something else, and you probably want to go looking for it.
Very good. Yeah, so these are, again, excellent advice from somebody who knows about those things a lot more than I do. That's great. Secondary, again, the question, something that I've seen maybe a little less, but, classic story, an obese teenager or maybe even a child comes to the ER. For whatever reason, we get a CMP, and I'm not denying it. Sometimes it's a mistake to get that CMP. But the glucose is very elevated. The kid is fine, clearly obese, very likely first presentation of type 2 diabetes. What do you recommend we do?
Absolutely. I hear you. We sometimes just CBC CMP is just that reflex where it gets sent off, get a urine, you see glucosuria, whatever it is, and we accidentally diagnose that child with probably diabetes.
That's why I tell the residents getting unnecessary tests is like picking your nose in public. What are you going to do if you find something?
What are you going to do with it? That's absolutely right. You're like, oh man, now what?
Now we're stuck.
But like you said, there's been a sharp rise in kids with type 2 diabetes, kind of correlated with the sharp rise in this childhood obesity. Just to throw some numbers at you, in like early 2000s, there were about 9 cases per 100,000 kids. And then just 11 years later, we're up to 14 cases per 100,000 kids. And as we've seen more and more, the racial or ethnic disparity is huge. At the end of that study, where there were 14 cases per 100,000, among non-Hispanic white youth, the incidence of type 2 diabetes was 4.5 per 100,000. Among Hispanic youth, almost 21 per 100,000. And among non-Hispanic Black youth, almost 38 per 100,000. So the increases there are just crazy to me that this disparity still exists, but it does. And so we're going to see it, and we're going to have to treat it. And like you said, a lot of times the kid might be otherwise fine, and we kind of accidentally discover this, or, you mentioned maybe you haven't seen that much of it, but the problem here is if the kid comes in DKA or HHS, which we'll talk about a little bit, it's hard to differentiate those two, especially when it's DKA. We aren't going to make that differentiation. And so for these two, type 1 versus type 2, there's becoming this overlap between the two conditions. In type 2, you have insulin resistance, but you also have a relative impaired insulin secretion. So some studies have shown that as much as 80% of pancreatic beta cells are lost prior to the diagnosis of type 2, which was shocking to me to find out. And in contrast to type 1, this isn't antibody mediated. It's just the toxic effect of the high glucose that causes these beta cells to be lost. In type 1 diabetes, you have the absolute deficiency due to the destruction of those beta cells. And making the differentiation, again, is important, but not something we're necessarily going to do in the emergency room.
Right.
Some things, most kids, like we kind of talked about, who present with type 2, and if they're otherwise asymptomatic, and you find that they have an elevated blood sugar, if you see obesity, older age, generally after puberty, and signs of kind of physical exam findings of insulin resistance, like acanthosis, a little bit of high blood pressure, family history, and again, if they match the ethnic profile that we were talking about, you could safely say that we're leaning towards type 2 at that point in time. For me, again, if it's a kid who's otherwise asymptomatic, the thing we need to do really is that really, really close outpatient follow-up. Assure that they're going to see their pediatrician. But I would take it a step further in a kid who I think you can truly say has diabetes. If that number is absurdly high, if they have the glucosuria present, if they're completely asymptomatic and the diagnosis is maybe in question, talk to their primary doctor if you can get them on the phone and consider sending that kid home. But for me, if it's a slam dunk diagnosis of diabetes, if that number's in the 300s or in the 200s and they didn't just eat an entire box of Oreos, then I would really consider bringing that kid into the hospital to do the test to differentiate the type. Kids who have type 2, for the most part, the first line treatment is going to be certainly diet, weight loss, exercise, and then they get started on metformin. Most kids, unfortunately, aren't going to be controlled with just metformin. They are going to typically end up on at least a 2-drug regimen, whether it's metformin or just straight insulin, or some of these other more, newer medications like the GLP-1 agonists or the SGLT2 inhibitors. Those are now approved for adolescents as well. So a lot of kids are ending up on those too. Again, oftentimes kids will present, if you send off that CMP, you see the blood sugar crazy high. Let's say we're there for something completely unrelated, but then you go back and ask, a lot of times they will have those symptoms of kind of simple hyperglycemia, the polyuria, the polydipsia, the fatigue. Less often they're presenting with full-blown DKA or HHS. You'll see some kids present, again, these older kind of post-pubertal kids who have type 2 diabetes. You can see vaginal discharge, candidal vulvovaginitis, or tinea cruris in boys. But about 40% of kids are completely asymptomatic when they present with type 2 diabetes. Again, when they present severely, like DKA or HHS, those are pretty easy to identify, right? We're good at those. We do those things a lot, and the treatment is going to be the same. If it's DKA, you treat it like you normally treat DKA. For HHS, only about 2% of patients will present for the first time if they have type 2 in HHS. That's where you have the severe hyperglycemia, typically over 600. You have the hyperosmolality, and you have severe dehydration with little or no ketonuria. Those patients have more severe dehydration than a typical DKA patient does. And so you're going to really want to be consciously aggressive with your fluid resuscitation in those kids. Again, we're really not going to do the differentiating if there is question as to which one it's going to be, with type 2 or type 1. You can see kids with the increased A1C. If you want to send that off in the emergency room, that goes with a lot of times we'll kind of send off those labs initially to help out our hospitalist or intensive care friends. But those kids are the ones that's easy. You see them, you send off the labs and they get admitted. If they are DKA or HHS, they're going to the intensive care unit. Otherwise, if they're symptomatic and it's a slam dunk diagnosis, I'm going to bring them into the hospitalist team to either make the differentiation or get them started on the medications they need. And if there's question about it, if it's a very, very mild case in a super reliable family and you can talk to the primary doctor and they say, I am comfortable managing this, then potentially send them home and you can give them a script for metformin. Typically, they're starting on 500, but that one's a unicorn. That's more of a needle in a haystack, I'd say, than the easy send them into the hospital type of diagnosis.
Sure. And what I hear you say, again, very important for us PEM providers, Seth, for the most part, initial management of classic DKA, which we see all the time, and HHS will be very similar. Give the fluids, then start insulin with maintenance IV fluid, some point put dextrose in the fluid, etc.
Absolutely. Yep. You are going to be a little bit more aggressive with your fluid resuscitation in HHS, but for the most part, you're going to be doing the exact same thing. It's just a kind of terminology thing when it comes to the less ketones in HHS versus DKA.
Sure. Yeah. Excellent. Seth, thank you very, very much. This was really, really beneficial for us. Again, providers who pretty much saw kids all of their career. I think my single time seeing adults was in the fellowship in the adult ER and the adult trauma. And suffice to say, I don't want to insult everybody. Not fun months, but this is excellent from the word of the expert who has seen it all. I appreciate your time. And as you know, Seth, a little tradition in PEM Rules, the guest gets to choose the outro of choice. And is this related to being from Indiana? You like country? Is that where it's
I
from?
think it's definitely an Indiana thing.
Is it an Indiana thing?
Yeah,
Okay.
my dad grew up on, when I was a kid, I was listening to country music, and at first I fought it, and then I eventually gave in, and that's just my when I'm picking music, even the residents a lot of times they'll be like, "Can we please listen to something else today?"
Well, don't take it the wrong way, but I don't blame them. But anyhow, so I'm going to try my best. You wanted to hear something by Zach Brown Band. Never heard of them.
Excellent.
But if there's a guitar in that song, I should be able to do it. I'll tell you briefly. My very limited knowledge with country music is Elvis Presley. That's what I know.
There you
so
go.
we might have to defer to that.
I'm gonna open a whole new world to you, Yaron. It's gonna be great.
It's gonna be great. Again, Seth, thank you very, very much for coming on the show. Have a great day and appreciate your time.
Thanks, Yaron. I'll see you soon.
And that is it for today, guys. Thank you very much for listening to PEM Rules. I hope you learned from Seth and his experience and wisdom. I hope you continue to check out the website, check out pemrules.com. Please submit any feedback you have. If you want to come on the show and discuss any topic related to pediatric emergency medicine, however it is related, just let me know. I would love to have you on the show. As promised, this is Zach Brown Band. Gotta admit, never heard of them. Type of music I've never played. It's called Beautiful Drug. I hope you like it, Seth. That's the best I can do, country music or non-rock music related. I hope that will do. Have a great day and thank you very much.